Hello everyone, welcome back to lecture series on overview and integration of cellular metabolism. Today our discussion will be on inborn errors of metabolism. So we will be briefly covering these topics in few headings. I mean, we will be discussing the demographics, we will be discussing the importance, symptoms and examples of IM, we will be discussing few undiscussed disorders in our course like lysosomal storage disorder, mitochondrial disorder, mucopolysaccharidosis, and we also discuss the newborn screening criteria and method. So, to start with the demographic, why we are so concerned? I mean, this is why so important. First of all, due to the sheer number. The number of inborn error of metabolism disorder that is possible, and the number is increasing as the medical science is advancing and more diseases are discovered every year, if not every month and every week. There are more than 500 such diseases that are existent due to a defect in intermediate metabolic pathway. So, somewhere in the other, due to some defect, a disease is formed and there are more than 500 varieties of them. And to be honest, those are not very common. For example, a disorder like diabetes is almost hypertension, a thyroid disorder for example, these are very common. They can be found in almost in my family, neighbors and who not, alright. Every 1 person in 10 may have those disorders, but these are not that much common. For example, individually they might be very rare. When we are collectively considering all the commonest and rarest disorder, generally the incidence may be 1 in 800 to 1 in 2500 birth globally, worldwide. However, the country that we are staying in is the highest in population, right? So, we have crossed China, we all know 24 million births in India happened in the year 2011. That roughly corresponds to more than 65,000 per day, right? First leading numbers. Due to this issue, suddenly the number actually rises up to a grave problem in Indian scenario. So, we are very much concerned about this disease in spite of its rare incidence. Okay. We need to thank Sir Archibald Garrett, who coined the term inborn error of metabolism as early as 1909. These are not new disorders, they existed. Human metabolism or any metabolism in animals, they existed, right? But the fact that the disease or the symptoms or the presentations were due to a defect in metabolism, he was the one to pioneer that concept in 1909. He had many areas of research, and there is a term which is known as Garrett's tetrad, right? It consists of certain inborn error of metabolism combined together: alkaptonuria, albinism, pentosuria and cystinuria. All right. Of this 3 you have already heard. Pentosuria, can you tell me it is a disorder of what? I mean, what is excreted in urine? Pentose sugars. All right. Carbohydrates are excreted in urine. So, pentosuria along with alkaptonuria, albinism and cystinuria forms Garrett tetrad. MCQ question, one of them might be taken out and you need to correctly identify what are the components, what are the 4 components of Garrett's tetrad. But that still does not answer why we are so much concerned that we need to study these disorders in detail, so much detail. We are investing so much time in learning because of one very important thing: permanent mental retardation unless these disorders are treated. Most of these disorders, if not all, if are not diagnosed early, if not treated early, will result in intellectual disability, which is also termed as mental retardation. So, these are the disorders of babies. Undiagnosed, the babies will not grow up intellectually sound, they will be mentally retarded, they will become imbecile and their IQ scores will be lowered, which is a very much concern for the parents as well as the entire society. So, we need to identify and treat these disorders, but before identifying and treating, we should at least know what are these disorders, right? Anyway, so we have got methods. Now that we have studied the entire metabolism, we all know path, we all know the nitty-gritties of what is happening from where to where, we can have, I mean, we can categorize them and we can have some common approach by which we can have an idea whether this problem is due to phenylketonuria or maple syrup urine disease or galactosemia, because early identification of these conditions will avert fatalities or irreversible clinical effects. All right. So, if we can identify them early and treat early, the baby will grow up into adolescent and adulthood and will live a normal life. So, early detection is very important. All right. In some cases, there might be a triggering factor that is linked to acute symptoms. For example, acute porphyria, hemochromatosis, glucose 6-phosphate dehydrogenase deficiency. These are also inborn error of metabolism, mind it. But there may be a triggering factor. For example, acute porphyria comes with, leads to very much pain. All right. And we have discussed how administration of glucose will alleviate that pain. In case of hemochromatosis, repeated blood transfusion leads to that disorder. So, there might be a triggering factor for all of the diseases that we can identify, and if we can stop them, further deterioration of these diseases will also be stopped, right. So, these are the various importance of early detection. So, we are very much concerned. So, when we should actually consider a disease to be a metabolic disorder, or when we should at all consider that this disease should be included in our newborn screening program. All right. Number one, the criteria of those diseases are, those disease have got serious neonatal presentation, and mind it, any presentation in babies are serious, but among them there are few complaints. For example, failure to thrive, failure to suckle, growth retardation, mental retardation, abnormal social smiling. These are all phenomena that are ammonia toxicity, that is leading to increased intracranial tension. For example, kernicterus leading to severe brain problem, or brain development is hampered. So, those are all serious neonatal presentation that are one of the check mark to consider a metabolic disorder. Biochemical abnormality, liver dysfunction, neurological features. Multiple amino acid ureas have got neurological features. I got told you focal central neurological features like abnormal movement, athetosis, jerk, spasticity, opisthotonus, all those have been discussed. So, all you can relate and connect. This lecture is all about revision. All right. If you are expecting me to teach and discuss every disorder in detail, that is not possible, because I already know I have taught it and you have learnt it with me, and I trust you that you have already remembered. Whatever is new, I will be definitely discussing. So, multiple skin and eye symptoms. There are disorder like galactosemia, fructose intolerance, where we get cataract, right. Coarse faces, so signs of storage diseases. So, all of them are concerned when a disease should be considered as a metabolic disorder. These features, common features, classifies a disease under metabolic disorder. So, what is the metabolic pathophysiology that we know? All right. So, here is a condition where A is supposed to be converted to B, B is supposed to be converted to C, C is supposed to be converted to D, but and these all requires enzymes, right. However, there is a block in this step that is hampering the formation of C to D. Okay. So, what will happen? Accumulation of substrate. So, all of these cannot be converted to products. That is, specifically if you are considering this step, the C will be raised. You agree with me? You have to. Next, accumulation of the precursors. Because C is raised, A and B ultimately will also be raised, because they cannot be converted to C and then downstream to D, right. So, A and B will also be raised. Okay. That will lead to direction or redirection or misdirection of the substrate into alternate pathway. One such example is phenylketonuria, where phenylalanine, instead of being converted to tyrosine, was getting converted to phenyl pyruvate, phenyl acetate, phenyl lactate, right. Very easy to example, and you should be able to relate this analogy now. Otherwise, go back, revise, come back, listen. Next, deficiency of the product. Definitely D will be deficient, and that will lead to deficiency symptoms of D. If D is a metabolic product, for example, again in case of phenylketonuria, tyrosine will be deficient, products from tyrosine will be deficient, melanin, thyroid hormone, catecholamine, that will lead to multiple symptoms. The analogy, the mechanism is same for almost all metabolic disorders, and ultimately not only that, unwanted or secondary side effect by any one of the metabolites, they can get accumulated and they can exert any unwanted or damaging effects in the system. So, this is the basic pathophysiology of all inborn error of metabolism. Now, if you get a descriptive question regarding categorization or classify inborn error of metabolism, you should be able to mention at least 5 or 6 of this classification. So, disorders of carbohydrate metabolism, disorders of amino acid metabolism, disorders of lipid metabolism, mitochondrial disorder, paroxysmal disorder, lysosomal storage disorder, disorders of heme metabolism, trace metal disorders. Mind it, this lecture series did not cover vitamins and minerals, but there are disorders that also exist in vitamins and minerals that can be classified together. Okay. So, you can give a read of that in order to comprehensively answer a question if it has got more marks, and if vitamins and minerals are included in your syllabus, or maybe we will cover that in an upcoming course, alright, in a future course. So, that is beyond the purview of this lecture, but mind it, you should be able to name at least 2 or 3 disorders among under each heading. Okay, at least 2 or 3, there are 500. You are not expected to write a book, or even if your question has got 15 marks, right. Mention the important ones about which you know. Okay, and we have discussed more than that in the lecture series. Okay. Now, the next 3 slides we will be revising amino acidureas, right. These are nothing new. I will be just letting you watch the slides. I will change so that you can take a snapshot, you can make your own note, you can pause the video, you can memorize it in your own way if you have not yet memorized it by now. Okay. Moreover, this is not the entire class. For example, see tyrosinemia. There are again 3 types of tyrosinemia, 1, 2, 3. I have included the most important one. Okay. So, phenylketonuria, tyrosinemia, alkaptonuria, hyperhomocystinuria, histidinamia, MSUD, maple syrup urine disease, methylmalonic aciduria, cystathionuria, hyperprolinemia, citrullinemia. Believe it or not, if you missed any of the amino acid metabolism classes, and if you are attending this class without attending that class, this class will be daunting, it will be too much, or it will be over the board for you, right. But I hope you have not done that and you have already completed your weekly assignments for that week. Okay. So, we can go on and on regarding the symptoms. What you need to remember in each of these diseases, basically the enzyme, very important for MCQ, the clinical manifestation, that may or may not be that much important, but what substrates are getting accumulated, this is also again very important. For all the slides that I have shown you in the last 3 slides, this abnormality in the enzyme and that abnormal substance that is found in either urine or that is raised in blood, because we will be diagnosing the diseases with the help of those substances. Okay. So, that is why they are very important. This slide is also a common slide that was shown in previous lecture of fatty acid disorders, right, specifically the 3rd class of fatty acid oxidation. So, methylmalonic aciduria, propionic acidemia, medium chain acyl CoA dehydrogenase deficiency, okay, long chain acyl CoA dehydrogenase deficiency, glutaric aciduria. Why this is red? Because this is the most common disorder. I am not going into detail, you can simply recap and move on. Okay. Again, known slide, glycogen storage disorders were shown to you. Okay. Von Wieser's disorder, the most common disorder, glucose 6 phosphatase deficiency. We also learned why there is hyperuricemia in von Wieser's disease, very important. Why? Can you tell me? Glucose 6 phosphatase deficient, glucose 6 phosphate excess will be deviated to HMP shunt, excess purine, excess uric acid, gout. Okay. Regarding Pompe's disease, one way you can remember, you see Pompe's disease, von Wieser's disease will be a short note, you need to remember everything, right, from the clinical symptom, disease, treatment, the enzyme name, everything. In case of Pompe's disease, remember the enzyme name, it was already discussed, I am again recapping. In Pompe's disease, you can see heart failure happens. Okay. How we remember? Pompe, pump failure, heart is a pump, like, so pump failure happens in case of Pompe's disease, type 2 glycogen storage disorders. Again, this was also discussed. One easy way to remember Cory's and Anderson, right? ABCD. What is that? Cory's disease, debranching enzyme, Anderson's disease, branching enzyme. Okay, this is as much as I can give you in order to help you remember, but there are multiple things and you need to have a good memory, or you need to practice it over and over again, discuss with your friends, form a study group so that you write it over and over again so that you can remember. How you can remember? M. McArdle, muscle phosphorylase, M for M. Okay. So, these are few important things that you can remember. I am not going to text because I have exactly copied those slides that were discussed in the respective classes. These have been discussed in glycogen's metabolism. Okay. So, this is about it. There are 10 types of glycogen metabolism, but though the names that are deficient over here, type 8, type 9 and type 10 are not that much important compared to those that have got names. So, von Jerks, Pompe, Cori, Anderson, McArdle's, Hertz and Tarwe's disease. These are the 7 that you need to remember, all right. And the rest are actually less severe. The other ones that we have discussed are much more severe. And why glycogen storage disease leads to hepatomegaly? Glycogen is stored in the liver cells, liver enlarges. Okay. But there are few disorders that we have not discussed that we will be discussing today. Okay. Sphingolipidosis. So, what are sphingolipidosis? Mind it, these are inherited metabolic disorder due to deficiency of enzymes that degrade sphingolipids. Okay. So, we discussed sphingolipid synthesis, we did not discuss sphingolipid breakdown, but the diseases we will be discussing. Okay. So, what happens? The mechanism is same. So, since enzyme is deficient, multiple intermediate products will be accumulated and they specifically cause damage to the nervous system, liver, spleen and bones. Okay, sphingolipidosis. There are multiple examples, names that we will be discussing very soon in tabulated form for you: Niemann-Pick disease, Gaucher disease, Fabry disease, Tay-Sachs, Krabs. Those are important names that you should remember. Okay, we will be showing you a chart where it will be much easier for you to visualize. So, the symptoms are more or less common. The very first symptom that we are concerned about all metabolic disorder are neurodegeneration, developmental delay combining with hepatosplenomegaly, liver and spleen will increase in size, bone abnormality, progressive loss of motor and cognitive function. The mainly neurological function and storage functions are hampered. Apart from that, how we can diagnose? So, the general features have been discussed. The diagnosis also falls in line with various other metabolic disorders that we have discussed: clinical evaluation, biochemical testing, genetic testing and also imaging study, radiological studies in some cases. Okay. Newer treatments like enzyme replacement therapy, substrate reduction therapy, hematopoietic stem cell transplantation may be considered in specific cases, but not all cases, all right. And as I told you, in all metabolic disorder, the ultimate goal or cure is gene therapy, but that is under trial in most of the diseases. Okay. However, we can prevent these diseases by genetic counseling. If the family, there is a previous familial history of these disorders, a genetic counseling by proper matching up of individuals, if they have got a familial history, they should be warned that the baby might have the disorder. So, in that way we can prevent that. Okay. So, the prognosis actually may vary from case to case depending on at what age is detected, at what time the treatment options are offered. The prognosis may vary with management and care. So, now you can see this is the pathway of sphingolipid metabolism. We discussed about sphingolipid synthesis. So, we discussed our discussion up to here, where I told you depending on the, we discussed how head group is attached, how tail group is attached, and depending on the X, it can be either ceramide if it is only hydrogen, it can be choline, it can be ethanolamine. So, choline and ethanolamine belong to sphingomyelin. We extend that knowledge to let you know that if that is glucose, it is referred to as glucocerebroside, if it is galactose, it is referred to as galactocerebroside. If they are other sugars, for example, glucose galactose N-acetyl galactosamine, they can be called globosides, as well as if it combines with complex carbohydrates, these are known as ganglioside. These names are important for chemistry part all right. And for metabolism path, knowing each of this step and intermediate in detail is not recommended compared to the synthesis part. Of course, everything is recommended if you have already covered the basics, the must know and good to know area. It is always nice to know, because every other now and then one rare question may be framed from this chapter or specifically this cycle, and that will help to differentiate you from every other average student who may not have touched this area. So, studying a rare thing is good only if you have covered the very basics, all right. So, with that in mind, this is the chart that you need to remember. Niemann-Pick disease, again I told you, in this case what is important, this inheritance is important. Of course, the name of the disease and deficient enzyme is important, right. The symptoms are more or less common to all, so you may choose to not remember the symptoms, okay. The accumulated products are important, but more important is the deficient enzyme and the name. Inheritance, why it is important? As you can see, all of these disorders are inherited in an autosomal recessive fashion except Fabry's disease or Fabry disease, which is X-linked, okay. So, for example, Tay-Sachs disease is caused due to deficiency of hexosaminidase A. What accumulates? GM2 gangliosides, okay. In case of Niemann-Pick disease, sphingomyelinase is deficient. Mind it, Tay-Sachs is due to the deficiency of hexosaminidase A, and Sandoff's disease is due to the deficiency of hexosaminidase A or B. So, if the question says deficiency of hexosaminidase A leads to production of Tay-Sachs and Sandoff, will both be considered as an MCQ option. So, this is more important for multiple choice questions in case of competitive exams, okay. Next, Niemann-Pick disease, sphingomyelinase. Now, one thing is very important, there may be specific clinical features, you may not choose to remember all because most are common. Specific clinical features are important. For example, acroparesthesia. Acroparesthesia means tingling and numbness or loss of sensation, tingling and numbness of fingers. This happens in Fabry's disease. Finger Fabry, easy to remember, acroparesthesia in case of Fabry's disease. Erlenmeyer flask deformity, Gaucher's disease. What is Erlenmeyer flask deformity? If you are interested to know, it is a radiological. So, basically if you take a straight X-ray, there is a thinning of the femur. So, this is known as diaphysis, known as epiphysis. These are from your anatomical knowledge. Thinning of diaphysis leads to a formation where the distance between the two mid femur is much more compared to that of the. So, the distance is actually, there is an index that is compared to knee distance, and this whole thing looks like a flask, Erlenmeyer flask, right. So, this is known as Erlenmeyer flask deformity, and it is a characteristic of Gaucher's disease. And among them, if you encounter a short note, if you include all of these key points, your short note will be done. And if you still ask me, is there any single important disease which we should know from all of them? Answer is yes, you should know Tay-Sachs disease, because if you know Tay-Sachs disease and if you remember the other names and enzymes, you can relate the symptoms because they are more or less similar, okay. So, this is about sphingolipidosis. Next, we will discuss about mitochondrial disorders. Mind it, mitochondrial disorders, it is not specifically an inborn of metabolism, but still we are discussing, we are broadly discussing all inborn errors. So, I thought why not discuss in this context. So, mitochondrial disorders involve mutation, these are genetic disorders, they involve mutation in mitochondrial DNA, and you should know that these follow a maternal pattern of inheritance. Mitochondrial DNA, mitochondria comes from mother, okay. So, you can see in this case where the senior progeny, the father and mother was affected, and all of the children are unaffected because mitochondria, and all of the children are, because they are, mother is unaffected and mitochondrial diseases come from mother. Here the father was affected, and in this case the mother is affected and the father is unaffected, but all of the children are equally affected because they are inheriting the mitochondrial DNA from the mother. However, there is one thing, they are affected, but symptomatically they may not be the same because of something I discussed earlier, that is called genetic penetrance. Even if we have got the mutant gene, that disease may not choose to express fully or partially, depending on, this is known as penetrance, that is expression of genotype into phenotype. That is the concept which you should be able to clear yourself on your own from any textbook of genetics, all right, or from your fundamental concepts in +2 lessons classes, right. So, what are the mitochondrial disorders that you need to know for multiple choice question? Okay, I am not going into the much details. The mitochondrial disorders are actually a collection of combined disorders that are abbreviated depending on, I mean abbreviated because of the disease. So, see the name MELAS, or we often say MELAS. Why? Because it consists of myopathy, encephalopathy, lactic acidosis and stroke like episodes. Similarly, MURF, myoclonic epilepsy with ragged red fibers, NARP, neurogenic weakness, ataxia and retinitis pigmentosa. So, you see, so if you just remember the name in detail, you will be able to easily write what are the clinical presentations, okay. But specifically for competitive exams, you should remember this mitochondrial DNA mutation and tRNA mutation, the numbers, these are difficult to remember, but some of them have appeared in higher competitive exams and they might help you if you can choose to remember. Minded, this is one such chapter that you should revise at the last moment. There are multiple chapters that needs to be revised just before exam because these are very volatile information and it will go off because human mind behaves in that way. We need to revise at the last moment so that you can easily remember, and you need to write this over and over again, form a study group and discuss with your friends so that you can easily remember. So, ragged red fibers in muscle biopsy, as the name suggests, is found in MURF, and peripheral neuropathy is found in NARP. Eye problem, retinitis pigmentosa, eye problem that may lead to blindness is also found in NARP. Okay. Next, we move on to mucopolysaccharidosis. Again, these are storage disorders. Okay. So, inherited metabolic disorders due to the effect, due to defective ability of the body to break down complex carbohydrates, okay, that are also known as glycosaminoglycans. So, when these glycosaminoglycans, the enzymes that are actually degrading the glycosaminoglycans or GAGs are deficient, what will happen? The intermediate products of glycosaminoglycan breakdown will be accumulated. The rest of the pathology is very same. Even if I don't proceed, I think most of you will be able to tell on your own what is going to happen. So, they will be accumulated, their level will be high and they will lead to various problems. What are the problems? You can just simply close your eyes at this point and say there will be neurological problem, organ enlargement, skeletal abnormality, bone deformity, and bone deformity, especially in this case of mucopolysaccharidosis, leads to facial dysmorphism. There is a characteristic face that is present in mucopolysaccharidosis. Apart from that, neurological problem, hepatosplenomegaly, bone development defect are common to all other, just like all other disorders. So, they are actually depending on the enzyme variety, they are classified as number 1 mucopolysaccharidosis type 1, type 2, type 3 and type 7, like that. Okay, we will be studying it in a next chart. So, symptoms might appear in very early childhood. However, the severity varies from person to person, individual to individual, cases to cases. Okay. So, this is one specific appearance of a mucopolysaccharidosis case. Okay. Next, so how we can diagnose? Same, just like any other metabolic disorder, genetic testing, imaging testing, enzyme activity, clinical evaluation, all those will give us answers that we are looking for. So, treatment option, I mean if it is implemented early, it will lead to improvement of symptoms on affected individuals, right. So, early diagnosis treatment is very essential. How we can treat? Enzyme replacement therapy, hematopoietic stem cell transplantation, those are commonly used intervention for mucopolysaccharidosis. Okay, and just like all other metabolic disorder, supportive care, physiotherapy, pain management, because there are bone pain, respiratory support, they often help in fighting the other complications that are associated with mucopolysaccharidosis. Okay, and final answer to all metabolic disorders, gene therapy, ongoing research. Once medical science progresses into such an extent that gene therapy is available right at diagnosis, maybe these chapters will go into historical archives, and this will be of historical importance, but we are now not there yet. So, at this point of time we only rely on early diagnosis, medical care and comprehensive management, and that plays a crucial role in improving the quality of life of these individuals. So, this is how a patient of mucopolysaccharidosis looks like. Typical faces: bone deformity, short height, widespread pelvis, teeth deformity, facial dimorphism, there will be internal organomegaly, and this is the complete chart that needs to be followed. Okay. Again, just the name of the disease, specifically what are their types and what are the enzymes that are deficient. Okay. Regarding inheritance, here also just like the previous disorder, all are autosomal recessive except Hunter's disease, which is X-linked recessive. So, you need to remember the exception. Okay. The gene location, if it is too much to remember for exam, not an issue, but for those who are into clinics, who are already trying to diagnose the inborn manner of metabolism and who are already physicians and lab specialists who are undergoing these courses, mind it, these are the gene mutations that you should be looking for, these are gene polymorphisms you should be looking for in order to diagnose all of these disorders. So, you can take a screenshot and memorize this, and we move on to our next topic, which is the common symptoms of IMDs, inborn metabolic disorders. IM, those are same thing. Okay. So, they are often referred to as IMD. So, by now you should be able to tell what are the common symptoms. Symptoms means those are the things that a mother will complain for the baby: seizure, abnormal convulsion, okay, involuntary movement, reduced heartbeat, that is bradycardia, vomiting, diarrhea, dehydration, very common presentation, fever, up and down, shooting of temperature instability, abnormal muscular tone, the baby might be spastic or flaccid, there will be skin rashes, there may be mental retardation. This is the final common presentation regarding which we are so much concerned. If untreated, it will invariably lead to mental retardation, and it is beyond repair because it is a permanent mental retardation. So, in this context, let us see how we can diagnose this inborn error of metabolism based on very simple tests, because you see in India especially this is a huge problem, public health problem, and babies are being delivered in remote corners, remote areas where there might not be advanced diagnostic facilities, right. So, we need to be aware, or these are the few common physical features that have been found out by various scientists and physicians, which can at least shortlist the case to a suspicious case, which can be later sent to the laboratory. So, here we are discussing inborn error of metabolism and how a simply urine odor, the odor of urine, can distinguish them. So, glutaric acidemia, glutaric aciduria is characterized by a sweaty feet odor. All of these are MCQ, these terms MCQ. Maple syrup urine disease or burnt sugar, you already know, right. Boiled cabbage, hypermethionemia, very important. Boiled cabbage, hypermethionemia. In some cases, if hypermethionemia is not an option, often in case of tyrosinemia is an option. Okay. So, mind it, when hypermethionemia is an option, that will be the answer of choice in case of boiled cabbage odor. Mousy or musty odor in case of phenylketonuria, rotten fish in case of trimethylaminiuria. So, these are the few urine odors you should remember in context of inborn error of metabolism diagnosis. So, when So we have already discussed these this slide, but mind it, these symptoms may appear late. So often the symptoms occur in a child who is otherwise healthy at birth. So being a parent, one needs to be watchful. If the baby exhibits this symptom in ward, as a physician one needs to be watchful as well. Okay. So what are the studies that are directed by which we can classify these disorders? Okay, because in order to diagnose and treat these disorders, we first need to know, right, that either these are disorders of urea cycle, or these are disorders of carbohydrate metabolism, or this is heme synthesis disorder. So these are roughly few tests that can actually categorize those 500 disorder into a subclass: plasma ammonia, organic aciduria in urea cycle; plasma lactate, beta hydroxybutyrate analysis, analysis of free fatty acid; quantitative and semi quantitative analysis of plasma and urine amino acid, all right. Urinary plasma organic aciduria, organic acid, presence of organic acid can be detected; urinary mucopolysaccharides can be detected; oligosaccharides screening test may be done, and there are specific panel of tests for galactosemia that should be implemented. Okay. So I told you these genetic disorders can be prevented. Okay. So in order to prevent, we need to genetically counsel the parent, specifically in the here maternal screening is a common thing. So one of the concerns when an inborn error of metabolism might happen, that is advanced maternal age, all right. There are triple and quadruple markers in maternal screening. If those markers are positive, we consider positive maternal screening, that may increase the probability of a inborn error of metabolism. Familial history, prior pregnancy with such chromosomal disorder, familial history of mental retardation or birth defect, any abnormal ultrasonography, recurrent loss of pregnancy, previous stillbirth, infertility, ethnic based carrier screening, and consanguinity. These are all situation when we should refer a mother to a genetic counselor. Okay. And why we are doing this? We are doing this to prevent any inborn error. An inborn error of metabolism can be one such inborn error. Okay. So these points may be quoted in a multiple choice question. You need to wisely select the answers. Okay. So prenatal diagnosis of IM, prenatal means even before they are born. So the sample should be obtained from the trophoblast or amniotic fluid cell culture. It can be done by amniotic fluid amniocentesis, or chorionic villus sampling, chorionic villus sampling. These are the two techniques by which fetal material can be obtained, and direct detection of a gene deficiency by molecular techniques, or the gene product, that is the enzyme deficiency biochemical techniques, is the preferred diagnostic approach. Direct proof always proves the disease. Okay. So what are the criteria for which any disease can be included in a newborn screening program? We first discuss what are the criteria for disease to be considered as a metabolic disease. Now we are already knowing it is a metabolic disease. Why should we screen them? So number one, the disorder should be an important health problem. There are many milder disorder that might not possess any problem, right? That should not be the case. Okay. The disease should have a latent or pre-symptomatic stage. Means what? That can be a window where we can actually suspect or detect the disorder. Okay. The natural history of disease should be well known. The physician should be able to know what happens next. Then when the natural history of disease is known, it is much easier to diagnose. And lastly, there should be an accepted treatment. We are trying to find out the disease only because we can treat the disease, right? So there should be an accepted treatment. So if all these criteria are falling into place, then the disease can be considered for newborn screening. So what is the specimen recommendation? The specimen should be obtained if it is a neonatal disorder we are suspecting, especially it should be done in case of all newborns. In tertiary care center, for all newborns in the first 1 or 2 days of birth, It is generally obtained by a heel prick, and it should be repeated after 2 weeks in case of premature babies. For example, in premature babies, I discussed that liver, the conjugation system is not functional. So, they may have got unconjugated hyperbilirubinemia, but that will wane off as the baby matures, right. And there are few diseases which needs blood transfusion. So, if transfusion is a method of management, the sample should be achieved prior to transfusion. So, what are the initial screening tests? Initial very basic tests that can be done are electrolytes to evaluate the anion gap and acidosis, okay, because in many such cases the metabolic acidosis leads to a high or raised anion gap, or even in case of normal anion gap we can actually classify the disease based on their findings. Glucose hypoglycemia is the feature of most inborn error of metabolism, okay. Ammonia, hyperammonemia is common in case of urea cycle disorders and organic acidemia. So, if plasma ammonia is one important parameter that we should be considered in initial screening. Also, lactate to pyruvate ratio happens, I mean lactate elevation occurs in case of energy metabolism disorders, and high amount of lactate to pyruvate ratio should raise a suspicion, right. There are actually kits available by which a urine sample can be tested for almost 35 odd disorders. Few of them we have already discussed, right, and the names which are not common you can actually take a note from here. We have discussed Rothera's test, cyanide nitroprusside test, ferric chloride test, Benedict's test, 2,4-dinitrophenylhydrazine test for qualitative analysis of aldehyde or ketone group. All right, what is CPC test? Cetyl pyridinium chloride for mucopolysaccharidosis. We did not discuss, it is not a metabolic disorder, but we should know that. Ninhydrin test to detect any amino acid. Ehrlich's aldehyde test for porphobilinogens, Ehrlich's aldehyde test for methylmalonic acid, nitrosophenol test for tyrosine which gives a purple red color. So, basically what should be done is screening for all newborn disease can be done in small laboratories, because it is urine, okay, we do not need expertise to collect heel prick. So, urine, simply apply urine sample and test the kit so that to test what diseases are positive, and if suspicious results are found, samples are sent to higher central laboratories. So, these are the very basic preliminary tests. So, what are the advanced techniques for detecting inborn error of metabolism? Thin layer chromatography, that requires actually expertise, thin layer chromatography, high performance liquid chromatography, HPLC for amino acid ureas, gas chromatography, and MS for detection, mass spectrometry for detection of organic aciduria, and tandem mass spectrometry, which after its discovery in 1998 have revolutionized the disorder, I mean diagnosis. So, mind it, I have told you in multiple these lectures that if you are asked that tell me one method by which you can easily or confidently diagnose organic aciduria or any product of metabolism, answer should be tandem mass spectrometry, which is often abbreviated as MSMS. If this option is present in MCQ, this will be your answer, okay. And what are the genetic advanced techniques? I mean these are newer techniques compared to small labs, but these are also becoming common in higher tertiary care centers, okay. But DNA hybridization probe analysis, that is by directly designing a hybridization probe which can go and attach to the gene that is malfunctional. So, by that we can actually directly prove that the genetic disorder exists, okay. However, that might be a definitive test, but there is an advantage, they are very sensitive and specific. Only the person who have got the positive disease will give that test. If there is no negative test, it means we do not have the disease, and if the disease is positive, it means we have, if the test is positive, we have the disease, it means sensitive, and if we do not have the test positive, we do not have the disease. So, the test is highly sensitive and specific. Prenatal diagnosis is possible. So, samples I told you which is achieved from chorionic villus sampling and amniocentesis can be analyzed genetically, and even with small sample volume this definitive test can be done. However, it is not always feasible because the infrastructure cost is very high, we require dedicated and trained personnel, and it is very expensive to sustain, alright. So, definite diagnostics tests are specific enzyme assay, nucleoside, leukocyte, plasma, serum or red cell. So, specific enzyme assay, if they are found to be problematic or decreased or absent, then definitively the inborn error of metabolism is proved. And lastly, we come to therapeutic modality. So, therapeutic modality, again that may come as a long question, and you need to classify your answer under several headings, giving one mode of treatment and at least 2 or 3 disorder under that heading. So, substrate deprivation modality of treatment can be done in phenylketonuria, galactosemia, MSUD, fructosuria. High dose of coenzyme, remember in case of phenylketonuria also tetrahydrobiopterin was a coenzyme, that deficiency was leading to hyperphenylanemia. Okay. So, again high dose of coenzyme can be a modality of treatment. Enzyme replacement therapy, in almost all of the diseases where enzyme is deficient, enzyme can be replaced, often abbreviated as ERT. Inhibition of substrate synthesis in case of glycosphingolipidosis, bone marrow transplant or hematopoietic stem cell transplant, HSCT is the abbreviation, can be done in case of mucopolysaccharidosis, leukodystrophy, Niemann-Pick disease. Liver transplant in case of disease like Wilson's disease, alpha or antitrypsin deficiency, Crigler-Najjar syndrome. I discussed in Crigler-Najjar syndrome the definitive cure is liver transplant. Okay. Wilson's is a trace metal disease in case of copper, but you should know Wilson's disease treatment is also liver transplant. However, the final answer, the most definitive treatment of any enzyme deficiency because the gene is defective is gene therapy, and this is the holy grail, that goal that we are trying to achieve. Once we achieve that, we will be done worrying about the dreaded sequences of inborn error of metabolism. So, to conclude, we have discussed the demographics of IEM, we have discussed why early diagnosis is very important, we have discussed the symptoms, we have given multiple examples, we have studied newly the disorders of lysosomal storage, mucopolysaccharidosis, mitochondrial disorders. I told you where newborn screening criteria is applied, what are the diseases that are criteria where the diseases will fit to be in screening program, and also the therapeutic modality for inborn error of metabolism. These are my references for today's class, and I thank you all for your patient hearing, and get ready to revise all of the lessons because we will be coming to the end of the course very soon.